Hi, I'm Kim Correa, and thank you for having us here this morning. I am a Master of Library and Information Science student, graduate student at UBC, and I am presenting today with Dr. Michael Wood, who is a postdoctoral fellow at UBC and BC Children's. We will be talking today about research we are undertaking at the Digital Health Innovation Lab here at BC Children's Hospital. We are currently working on developing a tool to help inform pediatric post-surgical pain management, and we recently completed our first set of focus groups with family members of patients and patient partners, and those results are what we are going to be sharing today. And just before we get into our results, we do want to provide a bit of context surrounding our work. And as you may know, persistent post-operative pain is very common, affecting 1 in 5 children, and may last up to 12 months following surgery or more. Now, this chronic post-surgical pain is pain that is not otherwise associated with pre-existing problems or post-operative complications. So these are kids that are still experiencing pain well after their surgery has been completed. And this pain is extremely problematic due to the fact that it is associated with several harmful consequences. It can lead to a decrease in quality of life, which can look like difficulty due to pain of engaging in everyday activities, including social, emotional, cognitive, physical, and recreational aspects. It can also lead to an increase in opioid or painkiller consumption, potentially leading to addiction. There can be a decrease of trust in the healthcare system and a continuous use of healthcare resources, such as increased visits to the ER or hospital, walk-in clinics, etc. And therefore, improving pain management has been identified as a key area for improvement here at BC Children's Hospital. And as such, our research group aims to design an easy-to-use communication tool like a smartphone app or a web page that can successfully identify children at risk for substantial post-surgical pain so that we can optimize their care prior to surgery, which may reduce the number of patients with long-term pain following surgery, and thus reduce the number of patients taking painkillers long-term. However, this is a complex project that has 4 distinct phases to ensure successful development and implementation of our tool in hospital. And today we're going to be talking about stage 1. So as a preliminary step to designing this tool, we first aim to identify and understand 3 things. What risk factors can predict pain following surgery and are specific to BC Children's Hospital's patients, as well as identify what post-operative relevant outcome and experience measures are representative of patient and caregiver needs, so such as mobility and anxiety, and did the patient or family feel heard by staff members, were clinical care and discharge instructions clear? And how do we best collect this information in hospital and following the return home? Now, the study is currently being conducted at BC Children's Hospital here in Vancouver, where we aim to recruit parents of children who have recently undergone surgery and patient partners with lived pediatric surgical experience, as well as clinician and other allied health professionals with expertise in pain management and the recovery process. Focus group sessions are held virtually using Zoom video conferencing software in groups of 3 to 4 participants and last approximately 1 hour. Data are then analyzed thematically using in vivo software to identify which metrics to collect in future studies. And importantly, to ensure that our research is representative of caregiver and patient needs, patient partners contribute in most aspects of the process, from participation in the focus groups to informing the study design, its implementation, and the dissemination of our findings. So it looks like conferences and published manuscripts. And now to talk about the results, I will be passing off to Dr. Michael Wood.
Thank you very much, Kim. We're going to switch gears a little bit and now move into the results. So we've currently recruited 9 participants who have attended 3 focus groups. Most participants, 8 out of 9 or 89%, were female, with 56% aged less than 50 years, 33% being patient partners, and 67% being parents. Although preliminary, we've seen several domains, specifically 4, for data capture. First, there's demographics, which participants have indicated we should capture age, travel time to hospital, biological sex, ethnicity, household income, as well as psychosocial factors such as anxiety, medical phobias, post-traumatic stress disorder, obsessive compulsive disorder, And interestingly, parents have suggested that we should not only assess the kids for these psychosocial factors, but also the parents as well, in case they have pre-existing conditions. They also suggested that we should capture clinical characteristics. So these could be things such as concurrent conditions, or comorbidities, previous surgeries, as well as administered anesthetics in terms of dosing, or has they responded favorably or unfavorably to these medications previously. In terms of outcome measures, the main one that's being indicated is functional recovery. So this seems to be that people want to measure eating and drinking following surgery, bowel movements, urination, lack of nausea and vomiting. And the key one seems to be mobility, playing with friends, returning to school. Families really want their kid to return to normal function, see them go back to school, and being able to play with their friends. Participants have also identified several factors that may be challenging to measure, but are relevant to improving the quality of care for patients. So first off, we have clarity of discharge instructions. Again, if we're sending families home with these instructions to take care of their child, it needs to be clear and concise, and we need to assess that in some way. Additionally, availability of support networks. This is really getting at the fact that some people go home and might not have very much support. Some go home and have siblings that can help out, parents at home to help, family, friends, aunts and uncles. They go to school, have teachers that are very supportive, as well as their peers. And this may be important in terms of their recovery. Additionally, effective coordination of care. This is especially important in terms of complex situations, and when someone has to, see their family doctor when they return home, as well as coordinate with their post-surgical team, maybe physiotherapy, different pharmacists, massage therapists, etc. It gets really complex, and all of this care needs to be coordinated. Additionally, it's one thing to coordinate it. It's a second thing to make sure people actually have access to it. So this could be whether it's in their actual area that they live. This may be problematic. If they're extremely rural, they might not have access, and then they need transportation to get to this facility, which they may or may not have. And if it's something like physiotherapy, is it, as an example, is it covered in their insurance? Is there some way that they can pay for this out of pocket? It becomes very complex. Additionally, transparency of procedure-associated side effects, recovery, and aftercare seem to be very important. Parents, especially in emergency situations, felt like it wasn't always clear what could be potential side effects. Is the child going to be nauseous and vomiting after anesthetic use? What the recovery is going to look like? And what is the parent's involvement in that aftercare to ensure their child recovers well? Additionally, they were interested in covering the child's comprehension of the procedure. It's one thing to advocate for your child to get this procedure, but also being age dependent, do they have some sort of comprehension what's going to happen? It might sort of blindside them and upset them if they don't realize they're going for a very intensive surgery, maybe multiple surgeries, have a long recovery process, and are going to experience a lot of pain. So this was a very important measure parents indicated to us. Additionally, continuous monitoring and pain management. Once people leave the hospital and return to normal life, it's really easy in the hospital. Nurse comes by routinely, checks on you and the child. When you go home, you have to return to work full time. You might have multiple kids at home. Your child is returning to school. How do you monitor them, ensure that pain management is doing its job? Again, very complicated out in the real world. Although these are all challenging measures, these are important concepts to consider as we further develop our research program moving forward. And just because this is preliminary work, I thought it was important to end with future research directions. So we've identified 4 key domains of data capture: demographics, clinical characteristics, psychosocial factors, and functional recovery. We're going to conduct additional focus groups with patient partners, parents, clinicians, as well as other allied health professionals to gain additional insight into metrics we might want to capture and increase our sample size. Upon concluding this, we'll move into tool identification, where participants will return. They've told us what they want us to collect. Now they'll come back and tell us how we best capture this, both in hospital and once they return home. So this could be things such as, are there validated tools we should be using? Do we need to invent our own questionnaires and surveys? Do we do this digitally? Do we do a paper and pencil? Is it a mixture of the both? This is what's going to happen. They're going to come back and tell us what's going to work best for them based on their needs. Once we finish this stage, we'll move into data collection. We'll actually implement these tools to capture these variables, so that we can develop that tool that Kim was mentioning earlier that identifies children for risk of pain following surgery, so that we can hopefully effectively identify them and use this tool to visualize this score so that we can indicate this both to clinicians and family during their pre-surgical visit. Here are references for several of the key findings from previous studies that Kim mentioned earlier in our talk, if you're interested for further reading. And of course, I want to acknowledge our large team of supporters. I'm incredibly grateful to be a MyTax Elevate postdoctoral fellow and be working with the Pediatric Anesthesia Research Team, as well as the Digital Health and Innovation Lab. And our work is further supported by the Michael Smith Health Research BC, as well as the Digital Technology Supercluster. And of course, I also want to thank my amazingly talented supervisor, Dr. Matthias Gargas, for all of his guidance and contributions to this study, as well as our numerous co-authors on the project. And importantly, we really want to thank all of the families and patient partners and staff at BC Children's for all of their time, effort, and invaluable insight, as I wouldn't be able to present this work today if it wasn't for all of them. And of course, thank you to all of you in attendance today. So just as we close before going into the Q&A session, I just wanted to present mine and Kim's contact information. Feel free to reach out on LinkedIn or on our BC Children's email below. If you have any questions, want to collaborate, or just feel like chatting about research, we thank you very much for your time, and we look forward to the Q&A.